Hello.
A very good evening to everybody who has joined today. So, today we have for our webinar a very new kind of a topic, that is pediatric cancer pain. And definitely, this is one such topic where we would like to know and learn more about. And for the same, today it's going to be like a case presentation, and it's like a case history. I would say it's like a case story, right? And for delivering the talk on this topic, we have Dr. Archana Nankar with us. Dr. Archana is the founder and director, Precision Pain Clinic, Pune. She is also affiliated to multiple hospitals like MMF Joshi Hospital, Aditya Birla Memorial Hospital, Pune, Venser Hospital, etc. Dr. Archana has done her fellowship in nerve block and pain management
उसको भी
from
पेन का
Ganga Hospital, Coimbatore,
यहाँ पे
and
पेपर जो
she did her fellowship in pain management from Daradia, Kolkata, and
कैसे हो
basically
एकदम
it
बढ़िया
was a very good
आप सब लोग अच्छे
thing
बेटा कैसे
to for me to tell, because Dr. Archana was doing her fellowship when I was also doing my fellowship, so we were kind of colleagues during that time. And Dr. Archana won the first prize in Art of Workshop Presentation in ICRA Pain 2021, first prize in poster competition in WPSSP Con 2020. Quite a lot of firsts for Dr. Archana. And she's been faculty in multiple conferences and workshops. She also has number of publications in pain and has also co-authored many books, chapters in pain as well. So with that, I'd like to invite Dr. Archana Nankar to deliver the talk in today's very interesting topic. Ma'am, the floor is yours.
Hello, everyone. Good evening, everyone. First of all, I would like to thank Dr. Javed. Thank you so much to inviting me and giving me this opportunity as a part of your Algos webinar series. And yeah, as Dr. Javed said, that our association goes way back to our Daradia days, and where I learned a lot from him. He was like my senior, my teacher, and yeah. So thank you so much. Okay, let's start with the talk. So my title is The Girl Who Liked Teal. Teal is like a shade of color, which you will understand in the final slide that why I've named this topic as like this. So basically, we are talking about pediatric cancer pain in this talk. So I'll initially give a bit of a background of pediatric cancer pain worldwide as well as in India. And then I'll start with my clinical case and of course what happened as a result and discussion and then conclusion. So so introduction. So pediatric cancer is a growing global concern now. Okay, according to this 2025 case. So childhood cancer, it affects 2 lakh plus children annually worldwide. It is projected to escalate about 21 million diagnoses by 2030. Even in India, childhood cancers, that is age group 0 to 14 years, it constitutes about 4% of all cancer cases, that is 75 to 76,000 annually. And of course, the burden of pediatric cancer is beyond its incidence. Treatment uncertainties are there regarding this pediatric cancer. So pain continues to be the most distressing symptom and profoundly affects the child and the family's quality of life. The incidence of pain in advanced stages is about 70 to 80%. Only 40% cases are reported to be managed well worldwide. This is according to WHO. And most vital activity of WHO's cure-all framework. So this cure-all framework is especially developed by WHO for pediatric managing pediatric cancer cases, and one of the most important part of the framework is managing pain in the pediatric cancer. And studies have been conducted on the applicability of WHO step therapy to children, but uncertainties persist regarding opioid dosing and the use of adjuvant drugs. So how much dose of opioid should we give, what drugs we should give, what co-analgesics we should give. All this is bit uncertain. This is also supported by a study which was done in 2023. Now coming to Indian context. So what are the barriers to palliative care in Indian context? So first thing, patient, there is lack of awareness of a pain clinic, both among clinicians as well as patients. They always come to us in the last stage of the disease with severe pain. Then lack of adequate supply of opioids and other drugs for pain relief. So there is a lot of bureaucracy in India. There were two acts. One was the NDPS Act, that is the Narcotic Drug and Psychotropic Substances Act, which was in 1983, which reduced the opioid availability in India, and as well as there was strong bureaucracy regarding opioid availability. So that's why opioid consumption reduced a lot. And of course, there is opiophobia. So prejudice related to opioids due to exaggerated concern related to fear of addiction potential of opioids, and the risk of respiratory depression. So these two fear is there among clinicians as well for prescribing opioids in cancer patients. So that is always there. And of course, there is poverty and illiteracy. So these different barriers are there in Indian context. And this was supported by a paper in 2016 by Bhatnagar madam, and also another paper in 2022. So let's start with the clinical case, looking at this background. So 9-year-old girl, she presents with generalized body pain, predominantly in the chest, left in late evening in my OPD. She's inconsolably crying, sometimes screaming in pain, and could not sit still. She's very and she's accompanied with her parents. Pain has aggravated since last 2 weeks. It is constantly present and it is disturbing both the patient's and her parents' sleep. And she was only on tab Ultraset half BD. That is Ultraset, everybody knows, paracetamol 325 mg and tramadol 37.5 mg, and it was half given with no relief. And parents were from a faraway village. They were coming almost 56 kilometers. That is 3 hours road journey from Pune. Pune is my city. And they were staying at a place which is nearby my OPD. Nearby, that is again half an hour from my OPD. And they were referred by the treating oncologist, who was also from Pune. So she had been diagnosed as a case of thoracic Ewing sarcoma. This was way back in 2021. So last 4 years she was dealing with this cancer. Since then she had been once operated and had received chemoradiation therapy several times. She was currently not on any curative treatment, and she had history of admission to other hospitals in Pune for pain management. However, treatment was ineffective. She could not get adequate pain relief in other hospitals. So patient was conscious oriented, physical examination we are looking. So conscious oriented, restless. It was difficult to take vitals. She was not in any apparent respiratory distress. Her weight was 19 kg as told by the parents. And recent PET CT revealed advanced case of thoracic Ewing sarcoma. It was occupying the entire right hemithorax. It was causing significant collapse of the right lung, pushing the mediastinum towards the left side. There was pleural effusion, there was pericardial effusion, there was invading right paratracheal, paraesophageal, subcarinal, prevascular region, and also the recent labs were there, some hemogram and renal function tests which were normal. So this was her PET CT, which showed at that time. So now we'll start with the challenges and how did I slowly overcome this. So first thing, parents declined hospital admission. They directly declined. They were like financial constraints, so they didn't want hospital admission. immediate opioid access unavailable. So they had come late in the evening. That was so the pharmacy, which was usually where I send my patients for morphine, that was closed, the licensed pharmacy. And it was far away also. It was half an hour from my OPD again. And nearby hospital pharmacies, so I sent those 3 prescriptions I gave for the morphine to the patient's father, and I sent him to the nearby corporate hospital pharmacy. But again, they said that no, we do not have oral morphine. So he came back. So available medicine was only Dolo at that time, paracetamol. So I adjusted the paracetamol dose according to weight, and I stopped tramadol, and because I wanted to start morphine, and also in view of multimodal analgesia, I prescribed some adjuvant pain medication, that is pregabalin. At that time I prescribed and I asked them to take 25 mg HS. Then paracetamol dose slightly calmed the patient, so I adjusted the paracetamol dose. It is generally 10 to 15 milligram per kg, so I adjusted the paracetamol dose according to the weight. At that time, it little bit calmed the patient, but as soon as she reached home, again she had started crying. Now day two. So day two, I had sent him with a morphine prescription. So he went to the pharmacy, and now morphine prescription was available. Pregabalin 25 mg, 50 mg was not available. I had also written amitriptyline prescription, but that caused nausea with her, and she couldn't swallow the tablet. So morphine was available. So now I started morphine very slowly. Initially, I gave only 1/4 tablet. And then means I asked the patient to crush the tablet, and I just gave 1/4 of the powder. So that helped her. The screaming and the crying, it stopped. So I increased little bit more. That calmed her down nicely, and there were no other side effect. So slowly, so at this, I increased the dose from 5 milligram BD to 5 milligram TDS. This is all very slowly, close phone on phone monitoring. And then I advised some tab pregabalin, 75 mg half HS, because this 25 mg and 50 mg were not available. So patient had good effect with morphine. It stopped her screams, and I had increased the morphine to 5 milligram TTS. So this way it happened. Now the patient, uh, he didn't come again. He came directly after 2 weeks. Now this time the patient's father came to my clinic, and the patient and the mother were, I spoke to them on video consultation. So the screaming and crying had reduced significantly. She was not, but still at night, sometimes she got up with pain. So again, it was disturbing the sleep of both the parents and the child. So current treatment was 5 milligram TDS, and they were giving Dolo. They were afraid of increasing morphine, so they were giving Dolo 500 milligram 4 to 2 times a day because of fear of opioids. And other thing, pregabalin, again the pharmacist said that this is seizure medicine, so they didn't give it to her. So now I consult father about opioid safety and necessity. And again on phone, I titrated the morphine slowly, like every day. Then slowly it increased to 5 milligram 5 times a day. And finally, I was at 10 milligram 3 times a day. And also, I persuaded patient to give half a tab of pregabalin 75 mg HS. Now, again, he didn't come. Then he directly came after 6 weeks. So 6 weeks, this time the patient visited me at the clinic with her father. Okay, current treatment was morphine 10 milligram TDS, pregabalin 75 mg half HS, and paracetamol 500 milligram TDS. Now this time patient was looking calm, no longer screaming or crying. She was conscious. She was oriented. She was communicate. She was able to communicate with me, and she could show exact location of where her pain is. So I've shown the diagram here. So in the lower chest thoracic region, right side, she had some pain. So that she could tell, and she could tell that it hurts a little bit. That is what she could tell. And so this is the Wong Baker Facer scale, and still complained of moderate pain. So I increased morphine again to 10 milligram to four times a day. So this is the increment is like on the basis of how you increase the morphine titration. That is, we increase generally 1/6 to 1/12 the dose, 1/12 to 1/6 of the total dose of the day. So that way I was increasing. So so now 10 weeks. At 10 weeks, so almost 2.5 months, she again comes with both her parents. Both her parents come to me. And this time, the current treatment is morphine 10 milligram 4 times a day. Pregabalin, I had increased 75 milligram half BD, and paracetamol 500 milligram TDS. Now she's smiling. Patient is not crying at all. She's calm, active, alert, playing. And most important to note is that she had no other side effects of morphine. That is, constipation was very less. I was managing it with the Dulcolax suppository. There was no nausea, or there was no drowsiness, no sedation, nothing. And she was alert. She was playing. Only mild pain at the lower part of the chest. And she was also experiencing mostly uninterrupted sleep with this regime. So this was actually the last follow-up. In discussion. So adequate and safe pain relief was achieved in this case by strict adherence to WHO guidelines. So patient had severe pain. So I had to start with morphine. Morphine is the gold standard for severe pain, according to WHO guidelines. Judicious use of available medicines, cautious opioid dose titration with close follow-up, using multimodal analgesia, caretaker education and counseling, and most important is that minimal opioid side effects were observed in this patient. So this supports the concept that opiophobia can reduce to an extent with appropriate dosing and close follow-up and adequate knowledge, judicious use of available medicine, multidisciplinary approach, all this, and ensuring availability of opioids. You can give effective pain relief in our developing country as well. So it is achievable and essential, effective management of pediatric cancer pain, even in Indian healthcare settings, overcoming opiophobia, ensuring opioid availability, improving clinician caregiver education, individualized opioid therapy, and multimodal analgesia. So these are the critical steps. So why the color teal? So what happened was, at the last follow-up, this the oncologist, the father had again visited the oncologist. So was telling him to restart chemotherapy at that time. So I was counseling the father regarding that, how to take the decision. And that time I asked the mother and the child to just go to the balcony of the clinic, and there were parrots over there in the tree. So she spotted one of the parrot, and she said that. So I asked her, "Oh, what is the color of the parrot?" So she said green. So I was like, "Do you like it like that shade?" So she was like, "No, I don't like that shade." So she, and at that time I had this in front of me. So she's like, oh, this was like she says, "No, I like this one. This shade I like." So that shade is teal. It is bit of a bluish green shade, and means that states how clearly thinking she was, and how the dramatic effect morphine or whatever the treatment had caused from her, the first day when she came to me and the last day when she came to me.
Hello.
When was the connection lost?
Yeah, yeah. I think when you were talking about teal, no,
Oh,
the
okay.
specific case, specific. I think from there you can start sharing your screen again.
Acha, acha, acha. Okay, okay. Okay, 1 minute.
Thank you. Slide is seen. You can go back to
Yeah,
the teal
yeah.
slide, madam. Yeah.
Yes, yes. साथ नहीं है. Okay. Okay, so why the color teal? So this was like a small story, which took place at the last day when she came for follow up to me. So the father the father about decision making. So basically, what happened was that he had visited the oncologist again, and the oncologist was telling to restart chemotherapy for her. I was counseling the father regarding that, and at that time, just as distraction, I asked the mother and the child to go to the balcony of the clinic. So there, she spotted parrots in the tree. So when she came back, she said that I spotted a parrot. So I was like, okay, what is the color of the parrot? So she's like, it is green. So I asked her that, do you like that shade of green, the shade of that parrot? So she's like, no, I don't like that one. So and she, without asking further, she just pointed out to this bottle, the Bisleri bottle, which was on my table, and she said that I like this shade of green. So it is the teal shade, that is a bluish green color. And so teal, just it's a coincidence that teal combines the calmness of blue with the revitalizing qualities of green. It can symbolize mental balance and open communication. It is associated with tranquility and of the ocean or the jungle. So what I meant to say is that there was a dramatic difference between in her from the first day when she came to me and the last day. So she was, means with the treatment, she was so, with the crying inconsolability, she was now calm and a little bit playful as well. And so this was like and also the side effects, like there was no drowsiness or there was no fatigue. She was totally active and alert and communicated openly with me. That is what I wanted to say. Thank you. uh, you could hear me right now?
Yes, ma'am, able to hear.
Okay, okay, great. Thank you. Any questions or any discussion? Dr. Javed?
Thank you very much, ma'am, for a wonderful presentation. So I think more than a case presentation, it was a beautiful story which was presented, and we need to appreciate over here that that many of a time a human touch to a patient's treatment is very very vital. I think in this case we have seen how beautifully the biopsychosocial model has been incorporated and managed as well, not just the importance of reducing the pain, but also the importance of reducing the mental stress, inducing the calmness and everything, okay, in the patient, which is very vital to achieve wholesome, or if I have to tell the right word, total pain management has been done in this case. So the wonderful presentation as always, Archana ma'am. And
Thank you.
so yeah, I'll just open the forum for a few questions. So we already have one in the chat box.
Okay.
Yeah, it says, ma'am, Dr. Sujata is asking, how can we
Yes.
calculate the correct dosage of morphine for pediatrics?
Yes. So they have given the I have already shared in my slide one of the this wait, I'll show you. So basically, what I did was, this was new to me as well, because I was also handling, I'm not an expert in pediatric cancer pain, but but I had a lot of experience handling adult patients with cancer. So I referred this, and generally, means this is National Institute, that is US, this. So 0.5 milligram per kg you can start. Okay, but you have to titrate. Means what I did, though it was coming to be 5 milligram oral, maximum oral starting dose is 5 milligram. But I again reduced it more. I gave the child initially just 2.5 milligram, and then slowly I titrated it to 5 milligram TDS. And again, the same, means as you give in an adult, that is maximum dosage increase in a one day, it is 50%. Okay, 50% of the initial dose. So initially I gave 5 milligram BD. Her weight was 19 kg, so 19 to 20 kg, and then I increased it to 5 milligram TDS, like that. Uh, so you can follow this annexure, but again you have to give again, you can start from a lower dose than this as well. Am I clear? uh, is it okay? Everyone got this?
So if you have any doubts, you can unmute yourself and ask also if it's not clear.
Thank you,
Yes,
ma'am.
yes. Yeah, okay, okay.
Next, Dr. Anupama is asking any side effects of morphine observed in the girl, Dr. Archana.
Yeah. So that's the thing, that no, I mean, almost no side effects. There was no nausea. There was no constipation as well. I was giving her, I had already given her. So any patient you give morphine, you have to give laxative prescription. So I had asked to ask the parents to give Dulcolax suppository, or 5 milligram tablet Dulcolax. But she did not complain herself of any constipation, and also any no sedation, no respiratory depression. This study is there. Okay. Another study, Bakir et al. 2023. So this was like a single center study which was done in Turkey. Okay, so there they have done both outpatient pediatric cases as well as inpatient pediatric cancer patients pain management. And here also they found out that side effects of opioids in pediatric patients, they are less as compared to adults, or which was previously thought of. So that because most of the times what happens, we have this opiophobia, that it will cause some respiratory depression or it will cause addiction. But in this patient, nothing was seen. So and the key is that you titrate the dose slowly from low dose to increase the dose slowly, with close follow up and close monitoring. That's how you do it. Yes, thank you. Any other questions? Yeah.
Any other
Excuse
questions?
me. Can you hear me?
Yes, yes,
I want to ask one question that you have
yes.
started morphine.
Okay.
So I've heard कि when starting opioid like morphine, there is a
Yes,
dictum we have to give bi-oral according to on time and
yes,
QID dose 6 hourly we have to start.
yes,
So
yes.
as you started with a smaller dose, is it okay? But
Yeah.
is it like that कि we have to go accordingly or we have to start quarterly dose?
Yes. So actually, in normal adult patients, I give QID dose only. Okay, 6 hourly. But
Okay.
now, since this patient was pediatric, so I was very cautious actually. So that's why I was giving slowly initially, and that was helping her as well. But then slowly I increased it. So normally this is how it has to be done. So you have to give a QID dose, and at night you have to give double dose of the QID dose, and slowly you have to convert it into a sustained release dose as well. So this is like an immediate release morphine which we use initially, and then we have to convert it to sustained release. But I was a bit cautious in this patient because initially because of all the barriers, means she was not very close to me. She was in a village very far away. So that's why I was giving TDS, and but finally I made it into a QID dose like that.
Okay, thank you.
Yes. Any other questions? The the neuropathic pain medications as well. They are means there is no fixed doses, but generally pregabalin, the off-label dose is 1 to 2 milligram per kg in pediatric, and for again amitriptyline also it is 0.5 milligram per kg. If you want to know the doses of the drugs.
Ma'am, can we use patch, fentanyl patch, buprenorphine
Yes.
patch or something?
Yes. So, what is done is, so generally, uh, we have to start with the oral dose. Okay, means that is according to WHO guidelines. If the patient can swallow, you give a oral dose. Okay, but if the cancer has spread and patient cannot even swallow, at that time the indication is you give a transdermal fentanyl or a transdermal buprenorphine. Now in this case, she wanted something immediate. Okay, because she was in pain, lot of pain. So that's why I couldn't give her a patch, because as you know, the patch, the onset of action takes time, and again you can't titrate with the patch. Okay, titrate the dose with the patch. So uh, so generally what is done is you give morphine, you find out the total dose of morphine, and then you convert it into a transdermal patch. So generally the equation is like, for fentanyl, so generally there is 12 microgram per hour. So for if 30 milligram morphine is the total dose, then you give a 12 microgram
दही है
patch
दही
like that. Sorry. So you can give a patch, but initially you have to find out the total opioid dose, and then you can convert it into a patch like that.
Ma'am, how did you find out the total dose in a pediatric case?
Total dose, so that way only, means according to her response. That is, so she had slowly, she calmed down. Means initially she was screaming, crying, so she calmed down. Initially she was not communicating, right? So in the in the third follow-up, she started communicating well, and she said to me that there is still some pain. So then I increased the dose again. So that way I got the total dose to be 40 milligram morphine in the total day, 24-hour dose.
Can we give buprenorphine sublingual tablet in case of
Yes, we can give buprenorphine
severe
also
pain?
sublingual. Yes. Severe pain, yes, you can give. It is also available, 0.2 milligram sublingual.
0.2 milligram sublingual.
Yes, sublingual. Every 6 to 8 hours, again, you can give.
And many times cancer patients are admitted in hospital, and
Yes,
unknowingly or knowingly, many
yes,
surgeons or many doctors start with the all the medications simultaneously. Like they start with the buprenorphine patch also, along with the tramadol injection
yes,
also, and
yes,
Dexa and
yes,
everything. Then how to
yes.
escalate in this case? Like how to
So generally, what I do in hospital cases, I make them stop everything. I remove the
okay,
buprenorphine patch. I remove the tramadol. I stop the tramadol. Tramadol, it's actually not recommended now. Below 12 years of age, tramadol is not recommended. And buprenorphine again, as I said, we cannot titrate the dose once you apply a patch. So I stop the buprenorphine. I wait for the buprenorphine effect to wear off, and I start with morphine. Like that I do. And because then when you start with morphine, and once you have the total dose of morphine, we can send the patient home on that morphine dosage. Oral morphine. That is what I'm saying.
thank you.
Yeah.
Ma'am, suppose in a hospital setting, suppose IV
Yes.
morphine is available, can we
Okay.
first give IV and then convert to the oral form?
Yes. In emergencies, you can give IV morphine as well. Emergency means if the patient is in very severe pain, you can give IV morphine as well. and then it can be converted to oral. Uh, exactly. Actually, the oral morphine is, I think, one-fourth the sorry, 4 times the parenteral dose. Um, but exactly, even I'm not sure. I've not done this anytime, but generally we can do it. Yeah, it's according to guidelines. We can give IV morphine as well, and then we can convert it to oral in case of very emergencies. That is very patient is having severe pain. There are no patient is not able to swallow. Then we can give IV morphine. Dr. Javed, if you have any experience in this IV morphine.
Ma'am, one more question. Ma'am,
Yes.
if the patient is having severe mets and increased liver function and urea
Yeah, yeah.
creatinine and all, what will be the drug of choice then?
Yeah. So in liver function test and this. So again, in these cases, raised RFT and raised liver function test, again, you have to give a low dose of morphine, or we can give again buprenorphine, or I mean, in that cases, again, you can give a patch of buprenorphine. But again, a low dose of morphine. That is, you titrate. Very frail patient or very elderly patient as well. You give a 2.5 milligram morphine and you titrate it again. Now, again, you don't have to give it like a QID dose. You see the response of the patient, how much till what time duration he's getting the relief means, and then you give. Morphine is like the immediate release, means it is a shot on, so you get immediate pain relief, and it is not cumulative as well. It is, the drug is not cumulative, so you can, that is the best, I think, choice. You just give it at a low dose.
Okay, ma'am. Thank you.
Yes.
And ma'am, you just said you crushed the tablet. That was 10 mg tablet, so that you crushed it, or you asked her to take that tablet.
Yes. Crush the tablet, made it into a powder, and then make it into 4 parts and give a quarter of it, like that.
Okay, of the
or
10
or
mg tablet.
yeah, 10 mg. Or if you have to give 5 milligram, then with a blade you
Cut it
I
into
mean,
half.
you cut it, yeah, cut it into half.
Mhm.
Okay, I think the question session is done, I think. You, Dr. Javed, you want to add anything?
Ma'am, you just now told we cannot give tramadol to the pediatric patient. Is there
Yes,
any reason
below
other
12
than
years.
below
Yeah,
12
yeah,
years? What is the
below 12
reason?
years. So there are two
Convulsion
things.
is the one.
Yeah, seizure is one. Second thing, it has been observed that it may cause severe respiratory depression, tramadol, in pediatrics. And also, this is, you can't, again, titrate. Tramadol, you can't increase the dose, means it has a ceiling effect. Morphine does not have a ceiling effect. So tramadol has a, that is therein. But mainly this, that it is seizures. And second thing, it is not causing much of pain relief, not much effect of pain relief. And also the third thing is that it has been observed that it may cause respiratory depression, tramadol.
Okay.
Yes, so latest guidelines are that below 12 years you don't give tramadol.
Yes.
Any other question? Oh,
This lecture will be available on YouTube.
I don't know. I think you'll have to ask Dr. Javed about this. I think
Yes, okay. Because I
yes.
joined little late, so I
Oh,
don't know
okay.
what exactly this child was having the problem.
Oh, okay, okay,
What?
okay. She had, sorry, Ewing sarcoma,
Okay.
thoracic Ewing sarcoma. It was
Oh,
occupying the entire right hemithorax, pressing the
okay.
mediastinum, shifting the mediastinum, and also some pleural effusion. And it was eroding the 8-9 ribs. That means it had some neuropathic element also, the pain. And
Okay.
yeah, so.
In this, we cannot do some sympathetic blocks or something like that, T2,
Uh,
T3, or
sympathetic blocks. So, see, in child, it is very high risk again. Other thing, you will have to admit her. So, which the patient, in my case, they refused because of financial constraints.
okay,
In this
okay,
case, so. Another thing, again, pediatric. So we'll have to give anesthesia, all that. I mean, so it is a high risk to give this patient anything, any sympathetic block or such. Maybe
okay.
they must be doing. I don't. Maybe in government setting, or I don't know. But I
And
don't
what
have
was her
this
prognosis? What was her prognosis?
prognosis. So it was like the oncologist had stopped. Means there was no curative treatment going on. So they had
And
sent me
life
to,
expectancy?
yeah, life expectancy. Actually, the oncologist did not tell me anything about the life expectancy, but now it was less only. Means with the whole
Yes.
hemithorax, and she was having this cancer since 2021. So yeah, she had been operated once, and
Oh,
she had yeah. So it was already 4 years.
okay.
Yeah, when she came to me, so she was in the last stage. She came to me for palliative, means last advanced stage only.
So good insights for cancer, pediatric cancer.
Yes.
Any other questions? So, Dr. Archana, I think there are no more questions in the chat box,
Okay.
and
Yes.
only it is filled with appreciations for you, telling it
Oh, thank
wonderful
you.
presentation. So,
Thank you so much. Thank you.
uh,
Thank you, Javed, for giving me this opportunity. Thank you.
Praja, ma'am, and thank you for accepting our invitation. A very
Yes.
different topic, that is pediatric cancer pain, and I'm sure people
Yes.
have got very good insights from your
Yeah.
presentation as well as your answers for the queries.
Okay.
So,
Great.
thank you very much again, and
Yes.
thank you all for joining today's session.
Yeah.
And we look forward to inviting ma'am again for another very insightful topic or discussion.
Okay.
Okay, ma'am.
Yeah,
Thanks a
I
lot,
will
sir.
be very happy to come again.
Sure, sure.
Yes.